اليوم احنا بنتكلم عن موضوع يعني it's very nice and for those who are doing Arab board exam, I think some of the topics that we will discuss here often come in the Arab board exam. Today we will be talking about hereditary nephritis, collagen 4 nephropathies. بنتحكي about very lightly, very quickly about the features مالت diabetic kidney disease. We will be talking about monoclonal immunoglobulin deposition disease, immunotactoid glomerulopathy, amyloidosis, and fibrillary glomerulonephritis. I know it sounds like it's a lot, but hopefully we will be able to cover all these topics. Right. نبتدي بالcollagen 4 glomerulopathies. These يعني diseases, they usually present with a picture that resembles nephrotic syndrome. And why do we say nephrotic syndrome? إن هم يعني الكولاجين 4 glomerulopathies هم they are structural abnormalities في الستركتشر مال الجلوميرولار basement membrane. فعادة اللي يصير إنه يكون إن هذا المريض لأي سبب من الأسباب يكون يعني شخص صغير، ولأي سبب من الأسباب يسوون إليه فحص دوري، سواء حق التوظيف أو حق التجنيد أو whatever، أو فحص ما قبل الجامعة، أو يعني whatever، أو just an incidental check-up، ويكون اليورين ماله ويشوفون إنه عنده يعني increase in the red blood cells في اليورين ماله. ولكن ما عنده أي مشاكل ثانية. This patient doesn't have any other problems, doesn't have يعني dysfunction في renal function، في الكرياتينين، في اليوريا، ما عنده hypertension, doesn't have any of these other conditions. and يمكن حتى إنهم يسوون biopsy على أساس إنهم يشوفون ليش هذا المريض عنده هيماتوريا. هذا يعني ممكن يكون under the umbrella of what is known as thin glomerular basement membrane disease spectrum. وممكن إنه يعني إنه فعلاً it's part of syndrome اسمه Alport syndrome، وهذا عبارة عن X-linked autosomal recessive disease. autosomal recessive disease and أو إن هذا الشخص ما عنده Alport syndrome، ما عنده هذا X-linked syndrome. This person just have an ultrastructurally thin glomerular basement membrane that's not part of the Alport syndrome. And why is it important إن إحنا نفصل between a person who just يعني ultrastructurally has a thin glomerular basement membrane versus إنه يكون عنده Alport syndrome؟ إن في Alport syndrome it's part of a syndrome that affects collagen 4، والكولاجين 4 داخل في التكوين مالت ear، مالت eyes. this person يعني can develop later on hearing loss, can develop حتى sight problems in their eyes. It's very important إن إحنا يعني we diagnose Alport syndrome properly for the sake of genetic counseling. Okay. So how do we diagnose Alport syndrome؟ عن طريق immunofluorescence. Alright. خلنا الحين نرجع backwards. هذا patient presented with hematuria, يعني incidentally was found to have hematuria for just a regular checkup. سووا إليه a biopsy. A biopsy كان إذا كانت في ال early stages بتكون normal ما يكون فيها شيء. سووا إليه IF ما في شيء. سووا إليه the electron microscopy and they found إن اللامينا densa مالته أو مالتها very very thin. So ذكرون اللي احنا قلنا when we talked about the thickness of the glomerular basement membrane. قلنا إن البيسمنت membrane يتكون من lamina densa ولامينا rara externa ولامينا rara interna. واللامينا densa هو الجزء الأوسط اللي هو يكون يعني الدارك، ولازم يكون الثيكنس مالته تقريبا roughly the thickness of one podocyte. فإذا كان thinner than that احنا نقول ان احنا we are most likely dealing with a thin glomerular basement membrane. Are we dealing with Alport syndrome? We take it a bit further ونسوي الاميونوفلوريسنس حق الالبورت syndrome. شنو الاميونوفلوريسنس حق الالبورت syndrome؟ ان احنا عندنا we have basically immunofluorescence حق الالفا chain 3 والالفا chain 5 of the collagen 4. Okay. mostly males, and it is X-linked, they are more likely to be affected by the disease. والفيميلز يكونون carriers حق X-linked Alport syndrome, specifically in the alpha 5. what we do إن إحنا نسوي الستينينج على الاميونوفلوريسنس حق الالفا 5 chain of collagen 4. هذا جاهز يعني just like a stain immunofluorescence. إنزين and we see المفروض إن إحنا يكون عندنا continuous staining within the glomeruli for الالفا 5. إذا كان في أي break، إنزين إذا كان براويكم صور، إذا كان في أي بريك في الستينينج معناته إن هذا البرسن has an abnormality in the alpha 5 chain of collagen 4. alright. نفس الشيء حق الألفا 3. إحنا عادة when we stain for Alport syndrome we do both the alpha 5 and the alpha 3. and إذا كان في يعني بريك ممكن في الألفا 3 ساعات ممكن إن both of them, the alpha 5 and the alpha 3, sometimes only the alpha 5, sometimes only the alpha 3. And if the alpha 3 is affected, يعني which is يعني more rare than يعني إن تكون الألفا 5 affected. If the alpha 3 is affected, this means إن it can affect both the females and the males, heterozygous, to a similar extent. يعني الألفا 5 is more seen in the males, loss of alpha 3 is more seen in the females. Okay. Sorry, alpha 3 is seen with the females and the males the same extent, نفس same ratio. شنو البيكتشرز اللي ممكن احنا يعني تخلينا نفكر ان احنا we're dealing with Alport syndrome؟ اذا احنا ممكن ان هي بس عندنا thin basement membrane. Sometimes, especially in males, we will have what is known as laminated glomerular basement membrane. There is an abnormality in the structure of lamina densa of the glomerular basement membrane. فيصير عندنا شيء اسمه splitting. اوكي، يصير انه نوع اللي ينفصل هاللون كأنه يعني ينزع من نفسه، ولما ينزع من نفسه ممكن انه يسوي الينا باسكت ويفنج زي السله، يعني تعرفون لما السله يحيكونها like تعرف لما they make it يدخلون خوصة في خوصة خوصة في خوصة خوصة في خوصة they weave it together. نفس الشيء يصير عندنا هذا السبليتنج ويصير عندنا basket weaving. sometimes يقولون إنه ممكن يكون عندنا bits and bits of the lamina densa انتف which is called bread crumbs. All of these things كل هالabnormalities على الإلكترون microscopy تخلينا نفكر are we dealing with Alport syndrome. تشوفون هذا you think are we dealing with Alport syndrome, you have to do the immunofluorescence for collagen 4 الألفا chain 5 والألفا chain 3. all right right okay. إنزين لما يكون عندنا over a long time إنزين escape of البروتين and red blood cells من الجلوميرولار tuft طالعين برا هاللون من الجلوميرولار tuft into Bowman's capsule. As you know, this will cause injury to the podocytes. فلما يصير عندنا injury to the podocytes over a prolonged time ممكن إنه يتكون عندنا secondary FSGS، يتكون عندنا secondary focal segmental glomerular sclerosis. all right. One of the things اللي يعني تخلينا نفكر are we dealing with Alport syndrome لما يكون عندنا FSGS ويا interstitial foam cells. يعني what do you mean by interstitial foam cells؟ في tubulo interstitial compartment في بين tubules نشوف تجمع of foam cells هاللون. These are basically يعني injured tubular cells من كثر البروتين اللي is basically it's escaping فيصير عندنا interstitial foam cells. all of these can make you think are we dealing with Alport syndrome. This is just a closer look into the structural abnormality of the glomerular basement membrane lamination اللي يصير عندنا في Alport syndrome. تشوفون هني أصلاً ما تشوفون اللامينا دنسا. okay يعني you don't see it at all. صار لها splitting، جزء منها صار مني، جزء منها صار مني متنتف، صار لنا كأنه باسكت ويفينج، إنزين كأنه مخرم، كأنه يعني جايبين like a cannonball مالت مدفعية and they are hitting it ومسوين فيه تخرمات. One of the things that can happen عندنا بعد في Alport syndrome إنه يصير عندنا alternating between thick and thin bits of the glomerular basement membrane. So عندنا مناطق thick ومناطق thin of the lamina densa. All right, this is how it looks on the collagen 4 alpha 5 staining اللي هو alpha 5 chain of collagen 4 which is more common. وزي ما قلنا في alpha 5 it is يعني more likely affecting males and the females يصيرون carriers to just pass it on to their male offsprings. And if it was affecting the alpha 3, more likely it will be affecting the females and the males as a disease, يعني as a proper disease rather than them being carriers to the same ratio. But alpha 5 loss of the alpha 5 is more common يعني in Alport syndrome. فإذا كان how does it look normally بيكون عندنا complete staining of the glomerular tuft, all right, and it will be continuous. في الميلز بيكون complete loss، يعني it's completely negative ما موجود. all right. بينما في الفيميلز بيكون عندنا الموزايك pattern، زين إنه يكون عندنا bits مصبوغة و bits completely absent as you see here. bits that are highlighted with the stain and bits where it is missing. All right, so this is what collagen 4 structural abnormalities in the glomerular basement membrane looks like. And this is what it looks like in Alport syndrome. Okay, يعني this is something that you need to know about and something you need to look for when you look at electron microscopy pictures. Yeah, benign familial hematuria. It might present in the part 2 exam. Yeah والله أنا I didn't do the Arab board. أنا سويت ال FRC path بس ما يجيبون هذا في ال FRC path. ال FRC path يجيبون عندكم diabetes, يجيبون cryo, يجيبون IgA, يجيبون lupus nephritis, بس ما يجيبون عندنا شو اسمه they don't bring Alport syndrome or thin basement membrane. They might bring this as an MCQ question في العرب board, I think. محاضرة الدكتورة سارة ما أعرف. I'm unaware of that, guys. ما أدري. Is she with us in the group? I don't know. Anyways, diabetes. Diabetes, as you guys know, this is a metabolic disease. Okay, and basically يعني disease, whether it is because of diabetes type 1 or diabetes type 2, diabetes type 1 اللي يكون فيه أصلا إن البody is not يعني there's a problem with the pancreas and the islets of Langerhans and it's not making insulin, أو diabetes part 2 in which the body is resistant to insulin and there is يعني الناتج النهائي إنه يكون عندنا إحنا hyperglycemia. As you guys remember and as we all know, the kidney is يعني basically it's a filtration system. فلما يكون عندنا وايد glucose passing through the blood, through the plasma in the kidneys, هذا يسبب لنا أول شيء hyperosmosis. Alright, يسبب لنا hyperosmosis رقم 1. رقم 2 الجلوميرولاي they are عبارة عن blood vessels. blood vessels, as you guys know and remember من أيام ما أنتونا كنتون in medical school, لما يصير عندنا hyperglycemia يصير عندنا ممكن يصير عندنا glycalization of the blood vessels, إنزين إن they get glycosized. This will affect the actual structure of the blood vessels. يعني يصير عندهم increase glycogen deposition within the blood vessels themselves, and this will affect the function of the blood vessels, their job as a filtering system. It will يعني بصير عندنا thickening of the blood vessels. It's a progressive disease if it's left untreated, and what happens in بداية يصير عندنا thickening of the glomerular basement membrane أو the blood vessel نفسها, which we will not be able to appreciate على light microscopy. المرحلة الثانية بتصير وهذه ممكن تكون شوية tricky, إنه بيكون عندنا and يعني they don't often talk about this enough in books, إنه يكون عندنا شوية mesangial hypercellularity. Alright, يصير عندنا mesangial hypercellularity, بعدين يصير عندنا what is known as mesangial expansion. الميزانجيوم شوية يكبر. اوكي لأن يصير عندنا يعني thickening ويصير عندنا hyalinization and hyalinosis of the blood vessels, فبيصير عندنا mesangial expansion and mesangial hypercellularity. لما يتقدم أزيد يبتدي يصير عندنا mesangial nodules. اوكي هم يسمونها nodular sclerosis في بعض الكتب, بس يعني it's not really sclerosis, it's just like mesangial nodules اللي إذا كبرت you know it as the chemistial Wilson KW nodules في الميزانجيوم. ممكن يصير إن هذه الميزانجيال nodules تتوسع أكبر 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 وتسحب الجلوميرولار بيسمنت ممبرين عن الانكرينج بوينتس مالتها تسحبها على تحت، والسبب إلى أنه what is otherwise known as an aneurysm. Right. السبب إلى أن aneurysm ويعني يتجمع إلى أن نوع البلد between يعني مثلا هذه الحين over here can you see this؟ قولوا إنه صارت هذه الكي نوديول alright زين وسحبت تكونت هني وسحبت إلى أن هذا اللومن مال الجلوميريولس سحبته إلى تحت بيتجمع البلد هني ويسبب إلى أنه thinning صح of this glomerular wall okay فالسبب لأنه a microaneurysm and it is one of the very rare causes إنه ممكن يصير عندنا hematuria in diabetic nephropathy. شلون يعني واحد يقول اوكي شلون ممكن يصير عندنا hematuria في diabetic nephropathy because of these microaneurysms alright ان هذه النوديولا كبرت الكي دبليو نوديول كبرت وسحبت الى ان اللومن وصار لنا thinning of the glomerular basement membrane هني صار له aneurysm it ruptured وطلعت الى ان طلع لنا البلودز and the RBCs into the Bowman's capsule and through the it went through the urine. All right, and it doesn't only affect the glomeruli diabetes. Then it also affects all the blood vessels اللي ممكن نشوفها في الكدني. فممكن يسبب إلى أن arteriolar hyalinosis إنه يصير عندنا thickening and this kind of like PAS positive hyaline deposition within the arterioles. How can we know in we are dealing with arteriolar hyalinosis إن هي بتكون PAS positive. Okay, نروح نطالعها على ال PAS. This is on H&E. بس إذا كانت on PAS it will be as pink as this. It will be very pink. All of this is very pink. كل هذا is PAS positive. And this is important. And that's why we're talking إن إحنا لما نطالع renal biopsies, we don't only look at one stain. ذكرون إحنا قلنا دائما we look at several stains. on the H&E بنشوف الnodular والmesangial expansion. بعدين نروح على ال PAS وبيكون PAS positive. بعدين نروح على silver stain وبيكون dark. It's because this is basically يعني this is the position of glucose into this blood vessel. So it's not like an immunoglobulin, it's not amyloidosis, it's not any other deposition of any other particle. So it's going to be black, completely black على Jones silver stain. وممكن يكون عندنا thickening of the tubular basement membrane in the same way that increase of glucose will affect the blood vessels. It will also يسوي لنا glycolization of the tubular basement membrane. زي ما قلنا السيلفر ستين بيكون black and ممكن إنه يسبب لنا microaneurysm because of the mesangiolisis. It will pull back the nodule will pull back, the KW nodules will pull back the capillary lumen ويعني يعمل لنا نوع weakening within the capillary lumen and this might rupture and it might lead to the formation of a pseudo crescent. إنزين شلون يصير عندنا pseudo crescent؟ إن يجمعون إلينا all the epithelial cells and they basically stick to the to the glomerular tuft ويسببون إلينا focal segmental glomerulosclerosis. And we should not confuse this with a crescent formation. It's very important إن إحنا we don't misdiagnose this as crescent. هل هذا معناته إن people with diabetes do not get other diseases? لا, of course they can get anti-GBM, and they can get ANCA, and they can get all the other diseases. But we cannot, just because we saw one pseudocrescent, we diagnose ANCA. You guys know this is not how we work it. We have to look for other crescents. We have to look at levels. We have to look at ANCA levels, at the serology levels. And put all of these information together to make a diagnosis. Another thing اللي ممكن يجي إليكم في in the MCQ is the capsular drop. The capsular drop, again, is one of the things that is pathognomonic of diabetic nephropathy. And هذا البومنز capsule وتشوفون كأنه قطرة ندى هاللون طايحة. إنزين capsular drop. إنزين again, this is glycosylation, and it is dropping كأنها بتنزل على the glomerulus. And sometimes this is the only thing that you might see. يعني أساساً البيشنت مو معروف عنه. They've done the biopsy for some other disease, and incidental finding تشوفون capsular drop. وتشوفون electron microscopy, and we will talk about the features of diabetes on electron microscopy. You put these two together and you call a nephrologist and you tell them we suggest ان انتونا تسوون HbA1c حق هذا المريض to make sure ان he's not diabetic, because the features اللي موجودة على الكدني مالته suggest ان this patient has diabetic nephropathy. يطالعون ويردون إليكم يمكن plus minus يردون إليكم ويقول لكم oh yeah, you were right, the patient does have diabetic neuropathy. ممكن يتكون عندكم something called a hyaline cap, which is basically this kind of like very thin glossy material within the blood vessel في glomerular tuft, and this is basically hyalinosis of the blood vessel, of the glomerular basement membrane or the blood vessel due to diabetes. So on H&E بتشوفون expansion of the mesangium and this kind of like nodular sclerosis or nodular expansion within the glomeruli. وبتشوفونه إنه PAS positive, and it is positive for Jones أو silver stain بيكون عندكم black. And then على electron microscope, you will see that we have thickening of the glomerular basement membrane. على ال IF, I'll show you a better picture for the thickening of the glomerular basement membrane. على ال IF, incidentally شافوا إن there is something called linear staining of the glomerular basement membrane with tubular basement membrane. This is not to be mistaken with anti-GBM. All right. All what we have, it's not really staining, it's rather an accentuation. True staining بيكون مولع, بيكون يعني very, 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 very green. What we have here, and it's not يعني مو كأنه, it's not like a light, it's not like a light bulb, مو كأنه late, it's not really, you'll have to see it under the microscope to know what I mean. But يعني use your imagination شوية وياي, لأن this is very important. زين, and we can have IgG accentuation على الglomerular basement membrane and the tubular basement membrane, but it is not staining. It's not true staining. لأن if it is an anti-GBM على ال IgG, as you know, as we have discussed in our previous lecture, بتكون يعني هذه glomerular basement membrane بتكون مولعة. It's gonna be very, 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 very bright. But in diabetes, both the glomerular basement membrane and the tubular basement membrane بيكونون highlighted, they'll be accentuated, بيكونون بس يعني كأنه واحد ماخذ عليهم قلم وراس منهم على ال IF. All right. So this is the only thing we will find on diabetes. Other than that, we will not have any other abnormality على ال IF unless the patient has any other disease. طبعا that's another thing, and the patient can have dual diseases. One of the very first abnormalities احنا ممكن نشوفها في basically diabetes إنه يكون عندنا thickening of the glomerular basement membrane, the whole glomerular basement membrane, مو بس اللامينا densa كله على بعضه, يعني all of the يعني ال thickening of the wall, all of it is going to be very thick. How do we measure? احنا زي ما قلنا ان احنا we look into the lamina densa and we see the height مالتها, is it roughly the height of a podocyte, and if it is the same height then we have normal thickness. يعني you don't need somebody إنه يكون عنده واجد experience to let you know إنه this is a thickened glomerular basement membrane. You see this again, you call the clinician, تقول له so HbA1c, are we dealing with somebody with diabetic nephropathy? Other than that, طبعا الimportance of إن إحنا نسوي الإلكترون مايكروسكوبي in diabetic nephropathy إن إحنا نشوف يعني sometimes نطالع الnodules. We look, are we dealing with any other causes of nodular sclerosis or mesangial expansion, and we'll be talking about those. And not every nodule, as you guys know, معناته إن إحنا we have diabetes. مو كلهم KW nodules. Something else. طبعا this is not just related على electron microscope. زي ما قلنا, you will be putting features اللي تشوفونها في light microscopy, PAS, silver, IF, you'll put all of these together, EM, and you will reach to a diagnosis. حاولوا انهم يسوون staging حق الدايابيتيز, ما اعتقد انهم متفقين, and to be honest, this is just a proposal of a standardized classification. And يعني where I did my training, they were not using this classification. هم كانوا يسوون mild, moderate, and severe. Roughly it is the same thing. إن إذا كان عندكم بس glomerular basement membrane, this is يعني stage 1, which is kind of like mild. إذا كان عندكم mesangial expansion, إذا كان mild mesangial expansion, you're dealing with stage 2, and severe mesangial expansion بيكون 2B. إذا وصلنا إلى nodular sclerosis إنه يكون عندنا ال KW nodules, إحنا this is stage 3. and إذا كان عندنا يعني وصل إلى global glomerular sclerosis, actually الميزانجيال expansion وال KW nodules أدوا إلى أن الجلوميرولس كلها يصير لها sclerosis, and if it's more than 50% of the glomeruli يكون عندهم lesions from 1 to 3, because this is advanced diabetic nephropathy and stage 4. Like I said, يعني this is just a proposal إن هم يقولون إن يعني how severe is the disease, but to be honest, I think most of the nephropathologists are not using it. Rather, they're saying mild, moderate, severe. These are the different features of diabetic nephropathy. زي ما قلنا, this is the nodular sclerosis. This is from a paper from the American Journal of Nephrology Society, and this is just kind of mesangial expansion, nodular mesangial expansion. هني صار عندنا segmental sclerosis، إن إحنا صار عندنا يمكن microaneurysm، it led to a rupture، صار عندنا activation of the parietal podocytes الابيثيليال cells وسووا إلينا sclerosis. ممكن ان احنا حتى ان يصير عندنا focal segmental glomerular sclerosis. Again, we have pseudocrescent formation هني, extracapillary hypercellularity, and you can actually see, and then this is still not fibrosed. The cells are يعني rather activated, and this is the formation of a pseudocrescent, okay, extracapillary hypercellularity. Again, this is another extracapillary hypercellularity, and this is not to be confused with a true crescent. How do we know that we are dealing with a pseudocrescent? We look around, we have diabetic changes, severe diabetic changes, عندنا arteriolar hyalinosis, عندنا mesangial expansion, there are no other crescent formation, هذه الوحيدة. ما عندنا fibrinoid necrosis. So we are more likely to be dealing with this being a pseudocrescent due to a rupture of a microaneurysm. We have a question. Let's see, the classification. لا, it's not mandatory in the exam. All of this is extra information for you guys. على أساس إن انتونا, I don't think this comes in the exam. I don't think so. Like I told you, أنا ما أعرف وايد عن العرب board exam. All what I know about the Arab board exam is from what I hear from my residents who are doing the Arab board exam. But I think what you'll be asked is شنو الفيتشرز الكابسولار drop, nodular expansion or nodular sclerosis, those kind of things. But أتذكر واحدة من الريزيدنتس مالتي راوتني question in which somebody is presenting with nodular expansion, and it was PAS positive and silver positive, وبعدين حطوا is it amyloidosis, is it diabetes, is it this, is it in this case it is diabetes, right guys, because we know in silver is positive, and when the silver is positive is more likely to be diabetes. A deposition of any other particle or immunoglobulin بيخلي السيلفر يكون negative, right؟ لأن زي ما ندري where there is a deposition of يعني immunoglobulins أو immune complexes أو materials سواء كان immunotactoid أو fibrillary أو amyloid بسبب لنا gaps في السيلفر، فالسيلفر بيكون negative. FRC path part 2. No, FRC path. What is the difference between KW nodules and the hyaline cap? The hyaline cap is within the wall of the blood vessel. The KW nodules is within اللي هو expansion of the mesangium. لما هذين الميزانجيال nodules يصيرون كلش كبار يصير اسمهم KW nodules. Okay, right. Okay, so this is PAS sustain, and we have a formation of nodules expanding في الميزانجيum, and the question is, what is the diagnosis? And the reason I'm telling you that is 10% in Arab board about renal system. Okay, Zain Lafa, you are in the right place, right? We are talking about renal system here. You are in the right place, and hopefully you guys are it's making it more accessible for you. Right. So the reason I'm showing you this, and أنا عشان أقول لكم in very very rare instances يعني مثلا شفنا هذين النوديولز and they are PAS positive and سووا ال HbA1c ويحلفون لنا إن هذا المريض ما عنده diabetes. Okay. There is a rather rare disease. أنا أقول لكم إياه على أساس إن أنتونا those of you who will be reading renal biopsies in the future, there is a disease called idiopathic nodular sclerosis, and it's not a very common disease, بس يعني ممكن إنه يصيد لsmokers. It's linked with smokers, and basically it looks like diabetes, but it is not diabetes, and the patient ما عنده abnormalities, ما عنده hyperglycemia in his blood. Yeah. Right. Okay. إنزين الحين we progress. We talk الحين we will talk about the monoclonal immunoglobulin deposition disease اللي هو light chain deposition disease heavy chain deposition disease light and heavy chain deposition disease. Light chain deposition disease, it's the most common. شوفوا كل monoclonal immunoglobulin deposition diseases, they are related to, وأنا بحط لكم paper كلش حلوة. It's a bit long. For those of you who are interested. For those of you who are not, you can skim through it. And just know that such a thing exists. Monoclonal deposition diseases, these are related to plasma cell dyscrasias. And then there's an abnormality in the plasma cell. Regardless whether يعني this is actually a full-blown multiple يعني myeloma, or this is just a plasma cell dyscrasia, there is an abnormality within the plasma cells in the bone marrows. وإنهم they are secreting for us abnormal immunoglobulins. Light chain is more common than the heavy chain, and it's more common than the mixture of the light and heavy chain. وش اللي يطلع عندنا؟ اللي يطلع عندنا إن إحنا عندنا nodules. أوكي بالضبط نفس الدايابيتيز، لكن شوفوا شو يصير عندنا في السيلفر نيجاتيف، سيلفر نيجاتيف. أوكي ال PAS بيكون weakly positive أو يكون negative. والimmunofluorescence, and this is the important bit, the immunofluorescence, the light chains, the kappa and lambda, واحد منهم بيكون intensely positive والثاني بيكون intensely negative. Okay, هذا حق اللايت chains. Alright, فبيكون عندنا nodular sclerosis، بتقولون we're dealing with diabetes، تروحون تطالعون السيلفر، no, it's negative. تروحون تطالعون PAS, weakly positive or negative. It's not a pink, لا, it's not fuchsia pink. تروحون تطالعون immunofluorescence and you say, wow, it's restricted. الكابا أزيد من اللامدا أو اللامدا أزيد من الكابا. And when we talk about restrictive, we're saying إن واحد منهم 4 والثاني 1 أو 1 4 والثاني 0. Okay. And then you do the EM, and I will tell you about the pictures اللي موجودة في الEM. الهيفي chains إن واحدة من الهيفي chains، واحدة من immunoglobulins يكون عندها restriction. والlight and heavy chain is not that common, and basically إنه يكون عندنا restriction in one of the light chains as well as one of the heavy chains. How does it look في immunofluorescence؟ زي ما قلنا يكون عندنا intense staining for either إذا كان light chain, for either, which is the more common, and actually most of the cases that I have seen of either the kappa or lambda, and you might see it within the tubules, within the blood vessels, within the medium caliber arteries, within the small arterioles, or within the glomeruli. And now this is how it looks within the glomerulus. Okay, basically بيكون عندنا, and not always, to be honest with you guys, this is seen only in 50% of the cases. يعني احنا ممكن يكون عندنا monoclonal immunoglobulin deposition disease بس ما نشوف ديلين, إنه يكون عندنا very fine granules, electron dense granules on the inner aspect of the glomerular basement membrane, اللي هو وينه يعني sub-endothelial area, okay, of the glomerular basement membrane. يكون عندنا these very fine granules. شري كان أحد راش gunpowder زين على طول ال inner aspect of the glomerular basement membrane. من برا ما في. طالعوا this is our podocyte, this is our external aspect, this is the sub-epithelial aspect, ما عندنا. بس can you see how fine and granular they are? Very fine. They don't look like anything else. They are very fine. على tubular basement membrane العكس. Okay, they are on the outer aspect of the tubular basement membrane, and when they are there, you will see them on both areas. بتشوفونهم on the inner aspect of the glomerular basement membrane and on the outer aspect of the tubular basement membrane, and they are very fine, granular, electron dense deposits. Very fine. This is a comparison of diabetic kidney disease versus monoclonal immunoglobulin deposition disease. إن هني ال PS بيكون positive, هني ال PS بيكون negative أو weakly positive. بيكون عندنا ال accentuation of the GBM على ال IgG. Over here, we won't see بيكون عندنا, ما بيكون عندنا staining, بيكون basically عندنا kind of like sticky staining, or بيكون عندنا, if this was restricted, if this was truly the restricted one, يعني kappa, lambda أو any of the immunoglobulins, بيكون عندنا intense staining throughout all the nodules. كل النودولز بتولع. يعني شوفوا هني هذه يعني واضحة إن this is واضحة إن هذه expanded. يعني هني عندكم الميزانجل الميزانجم it is expanded, لكن ما في صبغة. It didn't pick it. But look over here, everything is picking up the stain. Everything is يعني bright. All right, so يعني all the nodules are bright because this is basically the position of the restricted light chain, and this is the position of kappa or lambda, واحدة منهم within the glomerulus. على electron microscopy, like we said, ممكن احنا نشوف sclerosis, ممكن نشوف thickening of the glomerular wall of the glomerular basement membrane in diabetes. ولكن في monoclonal disease احنا بنشوف these very fine electron dense granules on the inner aspect على the subendothelial surface of the glomerular basement membrane. Right, and we talked about idiopathic nodular glomerulosclerosis, which is linked to hypertension and smoking. All right, خلينا نشوف الأسئلة وبعدين نواصل. الترايكروم, to be honest, يعني it doesn't really play a part. It will highlight إن إحنا ما عندنا immunoglobulins. It will highlight that we don't have يعني immunoglobulins. إذا يعني مثلا if they were, say for instance, cryos, they will be seen on trichrome. إذا كانت إذا كانت مثلا يعني any other immunoglobulin أو immune complexes they will be seen. But if it is just a restriction without the formation of immune complexes ما بتكون موجودة على الترايكروم. The most important stains to look at here are actually the PAS and the silver along with the HNA. The trichrome, it doesn't really play that major role in just يعني المونoclonal diseases. Right. في أعتقد سؤال ثاني. There was another question. النوديولز لا ما بتكون positive حل silver stain زي ما قلنا where there is deposition there is negative staining for silver. Whether it is amyloid or fibrillary or monoclonal it's gonna be negative. بنتحكي الحين عن موضوع واجد مهم and very very interesting. Can I move this? Yeah, okay. Let's move it here. أنا براويكم شيء. Can I move it a little bit further down? All right. Okay. So بحاكيكم أعتقد إن هذا مهم حق الامتحان العرب بورد. There are 3 different diseases which can appear similar على light microscopy. And we will be able to differentiate between them على ال IF وعلى الإلكترون مايكروسكوبي. أوكي. دليل الثلاثة هما amyloidosis and versus fibrillary glomerulonephritis versus immunotactoid. Okay. Let's start with الامyloidosis. Amyloidosis, as you guys know, is basically the deposition of these amorphous kind of like material everywhere, anywhere in the body. يعني ممكن تكون في الجلوميرولاي، ممكن تكون the mesangium، ممكن تكون the tubule، ممكن تكون interstitium. And again, it will be PAS negative. And it's gonna be شو اسمه على ال IF it will probably be يعتمد. Are we dealing with AA amyloid or are we dealing with AL amyloid؟ يعني انتوا تعرفون ان الاميلويد في له انواع. في ال AL اللي هو amyloid light chain restricted والamyloid heavy and light chain which is rather rare, and then we have the AA amyloid اللي هو مرتبط بال prolonged infections. يعني واحد عنده cellulitis for a very long time أو واحد عنده tuberculosis or whatever، يعني a very prolonged chronic infection ممكن يسوي لنا AA amyloid. alright. على سبيل المثال let's say إن إحنا we are dealing with AL amyloid بيكون إن على ال IF everything is negative وعندنا restriction حق ال we have a restriction for the AL amyloid يعني either lambda or kappa. Mostly it will be lambda بس either lambda or kappa بتكون restricted. واحدة منهم تولع أزيد من الثانية، يعني واحدة منهم تولع واجد أزيد من الثانية. How do we differentiate between this versus بتقولون لي monoclonal الالكترون مايكروسكوبي؟ ممكن انتم تسوون كونغو ريد. اوكي، والكونغو ريد بيطلع لكم will be polarized وبيطلع لكم by green الجرين by fringence، او ان انتم تسوون الالكترون مايكروسكوبي and this is what we're gonna see. We will see basically haphazard medium-sized fibrils بيكونوا haphazard بيكونوا كأنهم يعني شعر كذي مفلوت على الأرض. Okay, everywhere there will be these fibrils within wherever there is deposition. بتشوفونهم في الانتستيشن، بتشوفونهم في الtubules، بتشوفونهم في glomerular basement membrane، بتشوفونهم في الميزانجيم. You will see these fibrils. And these are, in fact, not very, very big. These are around 16 nanometers. بتقولون لي شو عرفنا إن إحنا we are dealing with 16 nanometers. بقول لكم روحوا طالعوا الأكتين microfilaments داخل تروحون هني تشوفون هني هذه الأكتين microfilament داخل البودوسايت وتطالعون ديلين. If they were the same thickness, okay, you are dealing with amyloid. If they were thicker, like هني, you are dealing with fibrillary. All right? الاميلويد thickness مالتها they were about 12 إلى 16 nanometers, and fibrillary they actually look like يعني straws زي القش. أنا أقول لكم هذا زي الشعر، هذا زي القش، هذا M10، هذا أكبر. Okay, and it is يعني something between 23 إلى 28 nano. زين again we are comparing them. طالعوا هني هذا very small actin microfilament within the podocyte. Podocyte يتحركون لا عندهم actin microfilament. If it's the same thickness it is amyloid. If it is a bit thicker then it's fibrillary. Immunotactoid you will not miss it. They are like microtubules, very well organized. هذين haphazard, high haphazard, high haphazard. This is very well organized. They're microtubules. They are like كأنهم يعني أعواد كأنهم I think يعني كأنهم اسطوانات. Okay, they're like microtubules كأنهم اسطوانات. إنزين وهذين الدوائر عبارة عن trans-section of هذين الاسطوانات and they are very organized. They're like forming small arches. Okay, تحكينا عن how does amyloid look like. How does fibrillary look like? Fibrillary in fact بيكون عندنا staining of one immunoglobulin زين اللي هو most likely to be IgG and staining of both ما عندنا restriction. Okay, بيكون عندنا staining of both the kappa and the lambdas. الاميونوتاكتويد بيكون عندنا staining of one immunoglobulin وبيكون عندنا staining of بيكون عندنا staining it's monoclonal بيكون عندنا staining of one light chain, either the kappa or the lambda. وبعدين we do the شو اسمه هذا electron microscopy, and we will see that actually we will be able to tell the difference between fibrillary and immunotactoid. وين يجي الصعوبة؟ يجي الصعوبة في between fibrillary and the amyloid. لأن اثنيناتهم they are just haphazard fibrils. Okay, how can we make the difference between these two? The amyloid, it will not stain for immunoglobulin. Fibrillary will. All right. Another thing is that there is actually an immunohistochemistry that is specific for fibrillary. وهذا immunohistochemistry stain اسمه DNABJ9. Okay, فهذا this is specific for fibrillary. All right. Right, let me see the questions. Tactile likes, okay, thankfully great. Amyloid fibrillary, okay, brilliant. All right, okay, نرجع. I will need another half an hour. Guys, are you okay with that? Quickly, قولوا لي على tell me on your chat box. Are you okay with another half an hour ولا تعبتون ونوقف عقب هذا and we continue next time? Okay. All right. Okay, fine. انزين so عندنا ال organized glomerular electron dense deposits نسوي عليهم الكونغو red. If it's positive it's more likely to be amyloid. زي ما قلنا it's like to be honest some of the references say 12 to 16 يعني أساساً أنا أكون وياكم صريحة not just 8 to 12 they can be up to 16. And fibrillary, it's more like it's actually bigger than 15. It's about 23 إلى 30, and the immunotactoid is much larger. So we've talked about all of this. Okay, amyloidosis. It's basically the position of amorphous amyloid protein. بيكون negative على ال PAS and بتكون positive على الكونغو red salmon color. It will be restricted على ال شو اسمه اللايت chains. خلينا نودي هذه فوق. Okay, sorry guys أنا ما عندي mouse. Right. Yeah, فوق روحي. Okay, almost there. Sorry. And then, yeah, so deposition of amorphous amyloid protein obliterating normal structures, and we'll have the fibrils by EM. And like we said, we will have restriction of the light chains. طبعا هذا إذا إحنا we are dealing with AL amyloidosis. إذا إحنا we are dealing with AA amyloidosis ما بيكون عندنا restriction of either lambda or kappa. بس على الاميونوهيستوكيمستري بيكون positive حق كونغو ريد، وعلى الاميونوهيستوكيمستري حق AA it will be positive. Okay, وبيطلع لنا الفبرلز بعد نفس الشيء. It's amyloidosis but it's not related to the position to light chains. It's not related to plasma cell dyscrasis. Okay. Right. Okay. We talked about the compositions of AL and AH amyloid, light chain or heavy chain, AA amyloid اللي هو due to related to prolonged infections. There are many types of amyloid. لو طالعون الchapter, it's like more than 20 different types of amyloidosis, but thankfully most of them they are positive for they're salmon colored for Congo red, and they have the same يعني look على electron microscopy. So regardless of what type of amyloidosis we are dealing with, they are common in these things, and it will be negative for PAS and silver. الفبريلري glomerulonephritis زي ما قلنا بيكون عندنا IgG and it will be polyclonal. Okay, ما شفت, I haven't seen a fibrillary. I've seen it's rather not a very common disease, but I have seen maybe around 30 cases out of لما أنا كنت في fellowship مالتي I've seen around 2,000 cases in 1 year, and of these 2,000 cases I have seen 30 fibrillaries كلهم كانوا polyclonal. فالفبريلاري بيكون عندنا يعني staining, very thick staining in the mesangium and predominantly in the mesangium. بيكون very thick staining على immunofluorescence for IgG, وبيكون the same thing على الكابا and lambda. It's not going to be light chain restricted. وبتكون weekly positive. هذا HNE. It's going to be weekly positive غير عن الأميلويد. الأميلويد بيكون negative على ال PAS. الفبريلاري بيكون weekly positive على ال PAS وبيكون negative على السيلفر. وبعدين زي ما قلنا الفبرلز they're going to be larger على ال على electron microscopy, and we can do immunohistochemistry اللي هو ال DNA JB9 and is going to be positive حق ال DNA JB9. This is يعني specific for fibrillary, right? So fibrillary is polyclonal and immunotactoid is monoclonal. Again, this is one way of kind of like differentiating between fibrillary and immunotactoid without electron microscopy. And على immunofluorescence, fibrillary is going to be polyclonal, بيكون عندنا both kappa and lambda as well as the immunoglobulin. والimmunotactoid بيكون عندنا immunoglobulin بس is going to be either kappa or lambda. والamyloid زي ما قلنا في ال AL amyloid ما بيكون عندنا immunoglobulin، بيكون عندنا only restriction of the light chain. Right, and طالعوا silver completely negative. Right, كنا محدد إليكم يعني outside of the glomerulus and it's completely negative. All of this is just the deposition of the immunotactoid within the glomerulus. Basically, they've done so many studies about immunotactoid, and they found in them لما يسوون electrophoresis for these patients, and زي ما قلنا, these are related to plasma cell discreases. فبيشوفون there is an M spike في electrophoresis of these patients حق IgMs. And there was a hematological malignancy in 38% of these patients, and those would include CLL or multiple myeloma. يعني it's very important that we flag out these diseases because the patient will need a bone marrow and probably a PET scan to look for hematological malignancies. Right. Very quickly بتحكي لكم عن proliferative glomerulonephritis with monoclonal immunoglobulin. وش الفرق بيناتنا وmonoclonal immunotactoid أو monoclonal immunoglobulin deposition diseases؟ إن this is just proliferative. إنه ممكن يكون عندنا crescent formation، يكون عندنا hypercellularity، endocapillary hypercellularity, as well as a deposition of IgG, an immunoglobulin, most likely IgG, and a monoclonality in the form of restriction of one of the light chains, either kappa or lambda. يعني زي ما تشوفون هني over here you have this is a trichrome, and the trichrome helps us, as you know, in kind of like seeing the lumen of the glomerular tuft, and over here احنا نقدر نشوف ان it's obliterated، عندنا endocapillary hypercellularity. فإذا شفنا ان احنا عندنا على ال IF the position positivity for IgG زائد restriction of either kappa or lambda، انزين then وبعدين شفنا على اللايت مايكروسكوبي ان احنا عندنا hypercellularity. We are more likely dealing with proliferative glomerulonephritis with monoclonal IgG deposition, and هذا ممكن يكون يسبب إلينا crescent formation in some instances. Is this important for the exam? Probably not. I'm telling you for completion's sake. All right. فعندنا an immunoglobulin, most likely IgG, restriction of one of the light chains, أكو lambda مولع، kappa ما في شيء، إنزين, and we have يعني electron dense deposits, mostly subendothelial. Mostly they will be subendothelial على electron microscopy. Right, خلينا نشوف the questions. Could you please open the lectures for 1 week? Precious and helpful. Rania, I don't know. Let me ask my colleagues and get back to you. Against honestly يعني it's against the policy مالت الجروب مالتنا، لأن بعدين people will not attend وبيتكسلون. Let me ask my colleagues and get back to you. All right. إنزين. very quickly بتحكي إليكم about the diseases اللي تتعلق في tubular interstitial compartment. ساعات الجلوميرولاي شكلهم نورمال، زين، ما في شيء، زين. المشكلة إن إحنا في الإميونوفلورسنس نشوف أشياء كأنها تولع داخل التوبيولز أو داخل في الtubular interstitial compartment، أما إن هي actually casts أو إنه light chain proximal tubulopathy. And what do we mean by proximal tubulopathy؟ هم ال resorption proteins إنزين داخل التوبيولز نفسها إنزين قاعدة تولع. ليش تولع؟ نرجع عليكم شوية على ورا في ذكرياتكم لما أنتونا كنتون in medical school. ذكرون البنز جونز proteins اللي هو المالتيبل مايلوما، اللي البيشنتس اللي عندهم multiple myeloma في اليورين مالهم they طلعون البنز جونز proteins. So all these excess immunoglobulins, as you know, لازم يطلعون، لا they have to go out. زين، مو شرط انهم يسوون لنا deposition within the glomeruli. ممكن ان هم basically يولعون الينا داخل الريزوربشن بروتينز مالت البروكسيمال tubules، ويبين إلينا على الكابا واللامدا إن واحدة منهم قاعدة تراوينا مثل يعني كأنه flickering lights شوية كذي مولعين، والثانية completely dark. إن عندنا restriction of these resorption droplets داخل الtubules. alright. فهذا اسمه light chain proximal tubulopathy. And we might be able to see crystals في tubules. زين، براويكم صور. We might be able to see crystals within the tubules, or maybe we will not. بس إذا إحنا متأكدين من اللي إحنا شفناه على ال IF وأخذنا صور and we are absolutely sure, we tell the clinician إنه we think that this patient has light chain proximal tubulopathy. يسوون إليه bone marrow biopsy على أساس إنهم يشوفون does this patient has plasma cell dyscrasis, or does this patient has multiple myeloma, or does he have a hematological malignancy. طبعا this is لازم تكون 100% متأكدين. Having a bone marrow is not biopsy is not pleasant. Okay. شلون الكاست تطلع؟ as you know إن بيكونون على الترايكروم بيكونون brick red color زي الطوب الأحمر، بيكون مكسر في cracks right. and most of the patients with light chain cast nephropathy عندهم multiple myeloma, about more than 90% of those. And basically this is how it's going to look like. داخل الtubules بيكون عندنا cracked casts and they're going to be brick red على الtrichrome. Right. And if we are lucky, we might be able to see إن they are restricted for one of the light chains على immunofluorescence إذا كانوا موجودين. لأن ساعات you have to remember البايبسي اللي عندنا في اللايت microscopy is not the same biopsy اللي موجودة عندنا في يعني يعتمد في الماتيريال مالتكم، لا as you know like in surgical pathology واحدة كور فيها التيومر واحدة كور ما فيها التيومر. So if we are lucky, we might actually be able to present إن إحنا هذه الكاست مالتنا is restricted for either kappa or lambda. اللايت تشين tubulopathy هاي اللي قلت لكم الريزوربشن droplets نفسها بتكون restricted for one of the light chains. تشوفون drop تكون مولعة. And if we are lucky, we might actually be able to see, and this is extremely rare, يعني هذه 1 in a million, إن إحنا نشوف crystals في light microscopy على ال PAS داخل ال epithelial cell مالت التوبيول. Very rare, guys. This is extremely rare. يعني هذه picture is 1 in a million. بس هذه, this I have seen. I have seen cases in which that we have proximal tubulopathy, light chain proximal tubulopathy. and we might be able to even في الإلكترون microscope داخل الابيثيليال cell مالت التubule. This is a tubule and this is an epithelial cell of the tubule. We might be able to show إن إحنا we have crystals formation داخل الtubules. بيكون شكلهم رومبويد، بيكون يعني شكلهم ما أدري هذا شو اسمه بالعربي، منشور معين I don't know، قولوا لي شو اسمه بالعربي. إنزين فبيكون شكله rhomboid and it's gonna be very dark inside the epithelial cell. And these are almost always seen with the kappa light chain restriction. lambda chain restriction يعني ما بتراوينا هذا الكريستالين inclusion. وهني بيكون diagnosis made على findings of the IF. يعني في lambda chain we are less likely to find the crystals، وبيكون يعني diagnosis is made only on the diagnosis of the IF على شو اسمه في الكابا we are more likely to see these rhomboid crystals في الالكترون مايكروسكوبي في التيوبيولز. اوكي الجلوميرولاي بيصير شكلهم نورمال.